Have you ever wondered how some people have severe anaphylactic reactions to drugs the first time they encounter it? Classic allergies require the person to have encountered the substance before and make antibodies to it. This is IgE. So how is it possible without prior sensitization? Today, we'll be talking about how this can happen and what it can teach us about non-IgE mediated allergies. Immunoglobulin E is the antibody behind classic allergies. Some still consider only these IgE-mediated allergies as true allergy. However, there are allergies that don't involve IgE, called non-IgE mediated allergies, as we have been discussing on this channel. And food allergies are not the only place you'll find non-IgE mediated allergies. A significant portion of immediate drug reactions might be non-IgE mediated. In fact, they are likely the predominant mechanism. How can a reaction not involving IgE be immediate? And how can they happen without sensitization? Remember, allergy reactions happen when an allergen binds to IgE on a mast cell, triggering it to release a bunch of chemicals. Mast cells can be loaded with a lot of IgE because they have receptors that are like magnets for these antibodies. The thing is, these high-affinity IgE receptors are not the only ones that mast cells have. They have a wide variety of receptors on their surfaces. One of these have an incredibly clunky name, MRGPRX2, or Mast-related G-protein coupled receptor member X2. Don't worry. As usual, I'll have any difficult names on the screen so you can see them. MRGPRX2 mediated reactions can occur the first time your body encounters a drug, though it likely requires a higher amount to react. It's also interesting that cofactors and comorbidities are likely important in these reactions, which are not essential for IgE-mediated allergies. For example, you may not react to a drug unless you took it while you had a fever or after a workout. I talked about cofactors before in this video. Yet other receptors bind to immune complexes and IgG. Reactions are also possible through the activation of the complement system, tiny inactive protein building blocks in our blood that when activated can send various chemical signals through our body. And there are yet other mechanisms through which drugs can trigger immediate reactions, including non-steroidal anti-inflammatories or NSAIDs through cyclooxygenase 1 or COX-1 inhibition, and drugs with inherent immunomodulator properties, such as monoclonal antibodies leading to cytokine release reactions. If your brain is spinning with all these letters and terms, let me tell you, that's a normal reaction. The big takeaway is your immune system has more than one way to trigger the alarm. Speaking of the immune system, I'm planning a video on the immune system on IgE versus non-IgE allergies. Subscribe so you don't miss it. And these are just the ones that can cause immediate reactions. Other mechanisms involving T cells or immune complexes can cause delayed reactions. So we have all these different mechanisms, but what do we even call these reactions? Drug reactions with negative skin test results used to be called pseudo-allergy. The European Academy of Allergy and Clinical Immunology proposed to abandon the term pseudo-allergy back in 2001. Considering the mast cell as belonging to the immune system, these reactions should be classified into non-IgE mediated allergic hypersensitivity reactions. Why does it matter that we know whether a drug reaction is IgE or non-IgE mediated? If a reaction is IgE mediated, even a tiny amount of the drug in the future could be fatal. If it is non-IgE mediated, the reaction could depend on the amount, which means a doctor might still be able to use the drug with a lower dose. And second, a drug allergy label often stays on a patient's record forever, which could limit the drugs that can be used for their care. It can sometimes include entire classes of drugs that are known to cross-react with each other, leading to less effective and more expensive treatments. If it can be proven that a reaction was non-IgE, then they can delabel patients and allow them to use these life-saving medications again when needed. If you had a drug reaction in the past and you suspect it could be non-IgE mediated, it may be worth consulting an allergist to reevaluate it. The problem is, distinguishing whether a drug reaction is IgE mediated or not can be challenging. If doctors can be sure it was the first time the patient was exposed to that drug, it points strongly to a non-IgE mechanism. And a positive IgE test obviously will point the other way to an IgE mechanism. But even that has exceptions, as some drugs can cause false positives by irritating the skin, for example. Certain drugs can trigger both IgE and non-IgE mechanisms, and their presentations can appear similarly, ranging from mild to life-threatening symptoms. Yes, non-IgE mediated drug allergy reactions can even cause anaphylaxis. There are now multiple known pathways to drug hypersensitivity reactions, and these can even occur in combination, potentially amplifying the reaction to dangerous degrees, including anaphylaxis. Even delayed drug reactions can be quite severe. Remember I talked about FPIES, or food protein-induced enterocolitis syndrome, the most severe and well-known non-IgE mediated food allergy? Well, there's a drug allergy version of that called drug-induced enterocolitis syndrome, with a rather unfortunate acronym, DIES. Yes, D-I-E-S. Which may very well be how you feel if you experience the symptoms reported in this very recent case study: vomiting, abdominal pain, and intense pallor 2 hours after ingesting the culprit drug. The symptoms reminded me of my own drug anaphylaxis reaction when I was 15. Although in my case it was administered via IV and the reaction was immediate. I felt a searing hot sensation spreading throughout my whole body before proceeding to a rapid drop in blood pressure and profuse vomiting. I have a suspicion that my body may have learned this pattern of reacting from this incident. Before then, my symptoms were chronic but more subdued, mostly diarrhea from infancy to childhood. I can't recall the exact timeline, whether the severe FPIES reaction, including vomiting and shock, appeared shortly before or after this drug reaction incident. It could have just been the hormonal shift with puberty. Estrogen is known to amplify allergic responses. On the other hand, we also know that mast cells can become twitchy or easily triggered after a bad reaction. It's interesting how our body remembers trauma even on a cellular level. Let me know if you'd like to hear more about how trauma can be connected to an overreactive immune system, including allergies and autoimmune disease. This is a lot of dense information, so I commend you if you've been able to stay with me this far. You don't have to remember all the details, but I hope you at least got the gist. Non-IgE mediated reactions are common in drug reactions. They are behind how it's possible that one can have a reaction on the first encounter with a drug. They can be immediate, severe, even causing anaphylaxis. And there are multiple pathways how this can happen, sometimes in combination with a dangerous additive effect. Have you ever experienced a baffling drug reaction? Does any of this help explain it? Let me know in the comments. Thanks for learning with me today. Stay curious, and I'll see you in the next one.